Okay.
All right. So take it away, Parveen.
Okay. Thank you, everybody, for joining us today. And today is the launch event for this particular issue for the creative nursing. Thank you so much for contributing to it as well. My name is Paveen. I work at the University of Sheffield and Doncaster and Bassetlaw Teaching Hospitals as a professor of nursing and professor of gender-based violence. Nursing because I'm a nurse by background, and gender-based violence because that's the research interest I have, and my work is around domestic abuse and overall how to support women from various backgrounds who are experiencing abuse. So I've been very privileged and fortunate to contribute to this particular issue as a guest editor and to also contribute one of the articles in here, thanks to Marty, who I've known for a few years now. And it's been a pleasure knowing her and the shaman working while not being in the same time zone and place. So we've been working on various different platforms, if you like, as editors and as people working on creative nursing issue. So thank you for joining, and I would like to give it to Marty to introduce and take this forward. And I just say that this has been done on behalf of University of Sheffield. So not only from myself, but from the University of Sheffield, please. Thank you for joining us. And I'm looking forward to learning more about your articles and also sharing my article with you. Thank you.
Well, thanks, Parveen. We're so glad for your hospitality in hosting this celebration. And it really is a celebration of the publication of our newest issue of the journal. We publish issues quarterly, and then our articles are coming out all along online first, but then every 3 months or so, we gather them into a theme issue. I'm joining you from Minneapolis, Minnesota in the US, and the Mississippi River is right outside my window. It's beautiful this morning. It's morning where I am. I wish you could all see it. And I live on land that is the traditional, historical, and legal home of the Dakota people, and in which the Anishinaabe people and others also have lived all this time. And there's a place that's particularly sacred to the Dakota people. It's called Owamni, which refers to swirling water. There was a waterfall there. It's right out my window. You can see it. And I'm personally committed to honoring and supporting their ongoing legal and spiritual connections to this land and our journal. I'm speaking for our journal as a whole. We're committed to presenting voices of Indigenous experience, including wisdom and knowledge of healthcare that has been marginalized or silenced altogether in the past. So on behalf of the editorial board of Creative Nursing, our official full name is Creative Nursing, a journal of values, issues, experience, and collaboration. That's our full name. So I welcome you to this celebration. It's volume 30, issue 3. We have a growing community of scholars, and these are thought leaders who are willing to write about and talk about challenging issues. Some of this is conversation that many journals avoid. And I just learned yesterday about a particular area of the United States where issues that we are talking about now, if a hospital even talks about them, they can lose their funding through the state legislature, which is a very sobering thing in itself. But we in the journal are committed to continuing these conversations. We welcome them. It's exciting for me to see authors in this issue that have written for us before, including Jennifer Lane and Hans de Ruyter. And several other of the authors of these articles are part of our peer review system, and they do these valuable peer reviews for us. Each year of creative nursing has an overarching theme, and our overarching theme for 2024 is the impact of social forces on nursing and health. And this theme issue 3, is consequences and disruptive solutions for social violence. I'm not going to tell you very much about the other articles here because the authors will be doing that. But I can tell you the theme of this issue, we originally, when we started planning this a year ago, the theme was just called social violence. But in putting the issue together, we had to confront all the ways that overt violence or the threat of violence pervades our lives as nurses and as individuals. And many examples, gun violence. One of our red board members said, nurses need to take a stand to stop it, not to try to adapt to it with bulletproof backpacks for kids what's up with that. The impact of mass shootings on healthcare staff, the dangers of street drugs, domestic violence, moral panics. To address each of these elements would take more resources than we have. Even though our publisher Sage is very generous with our page allotments, it's not unlimited. And then we realized that original title wasn't serving us because it implied that any article in the issue was necessarily violent, which was just plain not true. So we retitled it Consequences and Disruptive Solutions for Social Violence, because we're focusing on what we can do to recognize the processes that enable, promote, reward, and sustain violent behavior, and what can we do to mitigate those effects where we can. So the sobering, I've been using that word a lot, sobering. The sobering content in this issue is the business of each of us. And that's what I called my own editorial. My editorial in this issue is called Disrupting Social Violence is Everybody's Business. And that title comes from the article by Parveen and her colleague, Michaela Rogers from the University of Sheffield. She'll tell you all about their article in a moment, but they report on a service called Identification and Referral to Improve Safety, and the acronym is IRIS. So what they say is, this is a quote from their article, professional standards across healthcare reflect the recognition that responding to domestic violence and abuse is everybody's business. In their article, just very briefly, they interviewed service users who received specialist care. These people would disclose abuse to their primary caregiver, and the primary caregiver could then refer them to IRIS for specialty care around domestic abuse. And so they describe the fear and shame and secrecy that often goes along with these experiences of being a victim of personal violence, and also the promise of help that the IRIS program offers. There's a quote from a participant in the study there that just is in my heart. In a way, it's hard for me to relate to, but in another way, I understand it. This is what this person said. She said, if you've got a partner who goes through your phone, if they see in the contacts women's helpline, they'll be thinking, oh, she's in touch with somebody. So Iris is actually quite a good name. You'd just think it's a lady's name. Having to be that vigilant is something that I can't relate to, and I'm glad to have learned through this article more about what that's like for other people. So as I said, we need to be aware of these, and the awareness of this part of our lives is where we have to start. We have such rich articles to discuss today. After all the articles have been presented, we're going to have a moderated open discussion with an opportunity for questions and comments for the individual authors. And also, if you just want to talk about the theme of the issue, that's great too. We also encourage you to reach out to the authors personally. You can put stuff in the chat now. And then also, we are going to post their the corresponding authors' emails. I'll put that in the chat shortly. And please feel free to reach out to them with your comments and questions. The digital version of this whole issue of the journal is on our website. Several of the articles are open access, and the ones that aren't are free for 90 days. I hope I'm saying that correctly, Jessica. And then after that, it is a subscription-based journal. But if you want to have your institution have a institutional subscription, that's easily done, and we can help you with that too. So the recording of this issue and the annotated table of contents of this issue, which summarizes each article briefly, will be on our journal's website and also on our Facebook and Twitter, whatever Twitter is called now, pages, and we'll post those links as well. So I would like now to reintroduce Parveen, our host for this event, and to talk about her own article.
Thank you, Marty. And so yes, it's been a pleasure of sharing this particular article with Creative Nursing. So in this article, what we did was we reported an evaluation of a service called IRIS, which is Identification Referral to Improve Safety Service. So I'm not sure how many of you are aware of the different services or the issue around domestic violence and the role of healthcare professionals. So forgive me if I say something that you already know, and that's not the intention, but I just want to make sure that everybody is on the same wavelength. So domestic abuse, as you know, it's like, it's a very big problem, public health issue, which is affecting quite a lot of individuals, mostly women. Um, Not to say that men don't experience it, but the large majority of victims remain women. Large majority of victims of women experience intense and systematic abuse, and there is a fear factor involved with it. So men do experience violence quite a lot. Sometimes it's domestic abuse from their intimate partners as well, but the severity and the intensity is usually not that much, and the fear factor which is related to it is much less reported as opposed to when it is experienced by women. Men tend to experience abuse on the from people who they do not know anything about, from strangers, whereas women, for mostly, it's people and who they know very well. So usually it's intimate partners, husband, family members. A large majority is affected by that. So, and people often ask, why is it difficult for women to leave abusive relationship? There are many different factors, which include, for example, safety, concerns about safety for themselves, for their children. Many of them have been experiencing abuse for quite a long time, that they lose confidence and the ability to even think about how they are going to live on their own 2 feet if they are out of the system. And there is, in the context of UK, for example, there is a big fear generally that if I reported this, the social services will take my children away. And that then, or it's not good for the children if they do not see their father. And I think for that reason, they experience and they continue to stay in abusive relationships. Up until 2010, 11, 12, I can safely say that at that time when I was doing my PhD in gender-based violence and domestic abuse. So University of Sheffield is a very big university. And at that time, it was really difficult to find anyone else who is doing either a PhD in domestic abuse or even find a supervisor who was able to support a topic around this. If you talk to healthcare professionals, doctors, nurses, they didn't think it was their problem, because we were mostly concerned as nurses or as healthcare professionals with the symptoms or with the issues that are presented. So even an emergency department or GP surgery or some places, if somebody came up with bruises or kind of some sort of injuries, you were more concerned as to treating that injury and treating that kind of, the issue, rather than talking about the causes. And therefore, there was this thing about that it was not even mentioned into the notes of women that, they've got this injury, but how they've got it, there was no mention of this. So up until that time, nobody used to mention it. So then there is a drive where healthcare professionals like myself and many others started talking about domestic abuse and what is the role of nurses and healthcare professionals. And there is someone called Professor Gene Feder. He's a GP by background. So Iris Services was his baby. So they started working on this. What they thought that, GP services is general practices where everybody legally have to be registered. These are the places that people do come regularly for various different checks, for various different things. And in the UK context, GP surgery is the gateway to all healthcare services that you have to access. So be it secondary care, or if you wanted any kind of mental health support, or if you wanted a medication or things like that. So people would have to come in contact with GP services. What they figured out that healthcare professionals themselves were not equipped with the how to support people who are experiencing abuse, and especially, and that's the case even now. So we did a study a few years ago, and where it was nurses and doctors that said we can ask the questions, but what we don't know is what to do after that. What to do with the information that somebody has given us after we have asked them the question. We just don't know what to do with them. Do we refer them somewhere where how do we make sure that they're safe? So Iris service was one of those things which planned to improve the the understanding and provide training to the service. So when we say GPs, it's not only general practitioners, but people who work on those GP services to be able to identify and respond to people who are experiencing abuse, to then refer them to appropriate services so they can get appropriate support and appropriate management and can get out of that abusive relationship. During COVID-19, as you would have seen, that there was a lot of press which was saying that domestic abuse escalated. People were scared into living in the homes where they were, because they were in constant contact with the abusers, if you like. And this study was conducted at that time, where everything was shifted to telephone and online services. People were not able to see face to face in the healthcare services, and they had to opt for all those different things. As to what was the impact of the COVID-19 on the availability of services, so that's where we explored this particular issue. So we wanted to look at perspectives of patients and service users receiving specialist domestic violence and abuse support from the IRIS service during COVID-19 pandemic. So normally, if somebody went to GP and they said that, they were experiencing abuse, or GP or nurse practitioners identified or had that inclination that somebody was experiencing, they would say, well, why don't we refer you to this particular service, where somebody would sit down with them and explore in detail and would provide them with the referral. But during COVID-19, that was, quite limited. So we initially thought that it would probably be that people would say that their experiences were bad, but I'm going to tell you what did we learn. So we used a qualitative approach in this study, and we talked to about 11 service users, women, who received domestic violence and abuse support following their disclosure of abuse to healthcare professionals in the GP practice, and were then subsequently referred to IRIS service. So we have presented the findings of the studies in 6 themes, which included experiences of DVA during COVID-19, awareness of IRIS service, pathways to care, accessibility, safety, and remote consultation, and adequacy of telephone support, and impact of the IRIS support. So the first one, what we identified first, one that to our surprise, actually, most people said that they didn't really think the COVID-19 had an impact on the frequency or the intensity of abuse was any different for them. It was very similar. What it did do to them increased a sense of isolation for some people, and for others, it provided them with that catalyst and with that opportunity where they decided that I do need to do something about it. So, and I do need to get out of this relationship, and I can't really kind of, carry on like that. And maybe this was because that there was nobody, they couldn't go anywhere outside, they couldn't talk to anyone, they couldn't really share their feelings. And normally when we ventilate feelings and when we talk about things to somebody, that anger and that kind of, emotional hurt reduces to a certain extent, and you just think, oh, okay, fine, I've done this, and carry on with the same thing again. But when there was no opportunity to do this, I think it made some women to decide that that's it. I do need to think about getting out of this, and I do need to do something around that. So that was actually quite surprising for us to learn to start off with. Many of them who were experiencing abuse for very, very long time, it was something that happened during COVID-19, a similar kind of experience, but they just thought, that's it, I'm just not going to continue with that. So as I said, we talked to about 11 people. Most of them were in the age of anything from 30 to 49 years, and majority were between 40 to 49 years of age. Most of them were variable status of employment, and majority of them were from Black and minority ethnic background. So I've talked about their experiences. They didn't know much about the service. So a healthcare professional, did tell them that there is a service that we provide, and would you like to receive some support from them? So most of them went to the services thinking, okay, fine, I can do with something. And if there is another one who can talk about it or provide me with some help, that's all right. That's okay. So awareness of the IRIS and specialist DVA services was poor among participants, and that, I think, it may explains that why people do not necessarily talk about their experiences, because they just don't think there would be anyone who can support them. Once they have accepted or were made aware of services or were initiated with the services, they usually got a phone call. In the normal circumstances, they had to go to GP surgery and talk about it, which in some ways probably was another barrier, because people would decide if they have to go or not. Whereas with the phone call, it was a lot sort of, for some people, it was easier to just grab the phone and to talk to someone. So one of the participants said that I was actually to visit GP surgery, and through a very thorough conversation about events that had happened this year, the GP suggested to talk to somebody in IRIS to clarify things. And sometimes when things happen, you kind of brush them off and you don't know how to pinpoint them or what they are or what type of behavior you have. So therefore, I've explained those scenarios several times. And then the GP said that, you're experiencing emotional abuse and therefore you need to seek some services. So they needed that kind of prompting to be able to access services. Once they did, they felt that the service provided was really quick and people were quite quick to answer, and to listen to their feelings and to listen to their views about something, and to offer appropriate support, which the services could offer it to them. So I think that they found that really very, very useful. So for example, one of the victims says, the person contacted me in GP surgery and then via phone afterwards. I was experiencing abuse for more than 13 years. And by the time I was ready to explain my situation to anyone, they always asked me if it was safe to talk and if my children were around or not, so we could talk privately. So people appreciated that kind of privacy and thoughtfulness of in terms of what people were experiencing and what was sort of provided. They felt that they could talk to someone in detail, and the services which were provided to them were quite accessible. And the impact of IRIS support for most people was that they were able to think through their experiences. They were able to think through as to what they need to know. And again, when we make those decisions, sometimes when we are meeting people can make you question your decision. So during COVID-19, because people could not necessarily talk to somebody, so it was actually enabled them to think a lot about their decision and to not to have those second thoughts that, what is going to happen about if I did this, or maybe I shouldn't really do that. So they just had to sort of, made those decisions for themselves, and somehow it has been useful for various individuals. So several participants benefited from practical support from IRIS from when they left with their abusive relationship, because they provided them, connected them with appropriate services, who arranged for the housing services, or connected them with police, who were able to then get interim orders for abusers not to come in contact with particular families. So most people found that quite useful. So what we learned from overall that aspect was that what we were thinking that it wouldn't be a useful service, it actually was, but then it allowed us to develop some principles to with regards to telephone services, that when you're offering support to through telephone services as healthcare professional to somebody who is experiencing abuse, what are different guidelines that could be used for remote consultation. So you can find a table in the paper which gives a framework task about ask, what do you need to ask, how do you respond, how do you assess risk, how do you refer and signpost individual to services, and how do you keep a record into their into their records so that they can use later on for any judiciary sort of help which they need, or by any other health and social care professionals. So basically, this paper reports on the effectiveness of the IRIS service and the importance of thinking and listening and providing people with the opportunity to think through it, and the fact that you can always assess the risk and you can always provide services through telephone or online if you are prepared to think of the right kind of mechanisms to be provided, or mechanisms to be used, and the right kind of support to be provided to the individual. So I think I am quite over my time anyway, so I'll shut up and I'll be very happy to answer any questions. Apologies because I didn't know, I'm not sure how much immersed into the topic or not. So therefore I've tried to balance as much as I can. Thank you.
Oh, Parveen, well, and no, you don't have to shut up. And I encourage you to ask her questions in the chat and then at Q&A at the end. One of the most valuable things in that article for me, as someone who has been blessed to not experience that in any way, really, is the list of considerations that your professionals have in their minds when they're implementing and doing this program. So I'd like to then next introduce our next speaker. Jane Sparks is an assistant professor of nursing at St. Catherine University in St. Paul, Minnesota. Jane?
Thank you, Marty. And I have to start out by saying how honored I am to be included in this publication. The last time I published an article was in the 1980s when I got my first master's degree. So this was an experience that I had not had for a long time. I went back to school. Well, I like being a student, but I went back to school for my DNP I started in 2018, and it was in a course, and I actually went to the University of Minnesota in the Health Innovation and Leadership program, and it was in a course in that program that I had an assignment, and the task of the assignment was to apply the concept of the team of rivals to a public health issue that was important to us. And so for that paper, I chose to write about the issue of gun violence. And then it was I became aware of the Creative Nursing Journal and decided to rework that paper for this for submission for publication. So that was kind of the impetus for it. I chose gun violence, well, several reasons. One is that I am a grandmother to 7 grandsons, and you heard it right, sons. The oldest is 7. And as you would not be surprised to hear, males are more likely to be not only perpetrators, but victims of gun violence. So that made it really personal for me. And also, we can't help but anytime we turn on the TV, we hear about some form of gun violence. Just this week, sadly, we heard about it again. So it's a problem that is not going away for sure. And as nurses, I've been a nurse for many years, have only been in nursing education for the past 11, but we are in a unique position to well, not solve the problem. Initially, I had hoped that that might be a realistic goal, but I realized as I dug deeper into the topic that if we can even make an impact, if we can start making changes to decrease gun violence, that will go a long way. So getting back to my article, I was by no means an expert on gun violence when I started doing this research, but I learned a lot. I was also not an expert on the concept of a team of rivals. And if you read my article, you know that the concept first came to light by Abraham Lincoln, who assembled a team of people who were formerly his rivals when he was first elected president, and they became trusted advisors, and he learned a lot from them. And Doris Kearns Goodwin wrote a book about the team of rivals and the work that Abraham Lincoln did with that team. So what I learned from reading the book and researching gun violence is that there are a lot of different viewpoints and a lot of opposing viewpoints. And by really digging into those opposing viewpoints and looking at their strengths and their weaknesses, it really helps illuminate the problem. And it's definitely not a black and white issue by any means. And when I started digging, I realized that, for instance, one of the strengths of the position against further gun control is that the Second Amendment and the right to bear arms. And most of us might agree that that's important, but that doesn't mean that 14-year-olds should have access to assault rifles. So by digging deeper, looking at the strengths as well as the weaknesses of the opposing viewpoints regarding further controls on gun ownership really helped me to see that it didn't help me see what the solution should be, because after all of this, I still don't know what the solution is. But it told me that this approach, assembling a team of rivals, is possibly something that can help us get to a better place in terms of gun ownership. And that there is common ground, that even the people, the extremes on one side or the other, and there are more than two sides, obviously, but that most people don't want to see innocent victims killed as a result of guns. I think that is, in fact, I haven't done a survey, but I think it's probably safe to say that no one wants to see innocent victims killed. So that's one way in which we have common ground. So I learned to respect the approach. I also believe that there are things that we can do to make an impact. I also strongly believe that as nurses, we are in a unique position to help bring about change. One of the things that I plan to do as a result of writing this article and being published, I'm newly on a task force at St. Catherine University where I teach, to include more education on public policy and how, as nurses, we can impact public policy. And I plan to get involved in Minnesota in that process. I had a physician that I worked for at one time, and he said, an expert is someone who knows a little bit more about something than someone else. And so I like to think that I now am somewhat of an expert on this issue, and I'd like to be able to offer my insight, not with regard to the solution to the problem, but the approach that might be helpful in bringing about change. So I think those are the main points that I wanted to convey. But again, I am so honored to be a part of this group of authors, and I hope that the next article that I publish will not be 30 or 40 years from now, but sooner than that. That's my plan anyway. So thank you all, and I welcome any questions or thoughts during the Q&A.
Well, thank you so much, Jane. Thank you for that. And we're honored to have you as well. The next author has just joined us, Kimberly Jackson. She's an assistant professor in the Arthur Labatt Family School of Nursing at Western University in London, Ontario, Canada. And she can tell you about her co-authors. Parveen, Kim told me that she doesn't have slides, and we'll see how this works, because I actually have the manuscript on this laptop, and it's possible that I can share and show some of these pictures. But first, take it away, Kim, and we'll see how it goes.
Thank you so much, Marty. And it's really heartening to be here with a group of like-minded researchers. So I feel quite honored and privileged today. So thank you for this opportunity. So I'm just going to acknowledge the co-authors on this paper. So this was co-authored with somebody who I adoringly called my day wife. So this is Tara Mantler, who is my researcher partner who I do almost everything with. And Sheila O'Keefe McCarthy, who is out at Brock University. We did our PhDs together. Kara Davidston is a PhD student. Katie Shillington was a PhD student, now I believe doing a postdoc in California, and Julia Yates, who is also a PhD student currently. So thank you to those folks. So I'm really excited to talk about this paper. This is absolutely my favorite publication that I have done in my years as a professor. And the reason for that is because it's the most novel, and I believe will be the most impactful. So I've been an IPB researcher for 12 years and have numerous publications in sort of the standard reporting of studies. But this was the first foray that we had made into the arts-based arena. So we've done a lot more arts-based research since then. But this project was born from, as many of them are, out of necessity. So we were actually doing a randomized control trial. We were piloting a study that was an intervention for women who had had intimate partner violence and who were getting ready to deliver and were sort of flagged as potentially having difficulties with their birth as a result of their histories, their trauma and their history of violence. So we had a partner who was doing an intervention, which was trauma and violence informed care, that she was sort of weaving into her cognitive behavioral therapy that she was doing to help ready these women for their deliveries. So basically trying to prevent, re-traumatization, triggering and so forth, and getting them ready for some of the things that they might be experiencing through their birth. Long story short, Ontario is not in a great way in terms of our healthcare system. The funding was pulled for this program, and we had to stop recruiting in the middle of the study. So, we were left with a really small sample, but we had some really, really fantastic qualitative research from interviewing the participants that we had. And we thought, well, how are we going to get this out there? Because what they were saying was just like this program was, they said, life altering. They said they had these sort of pivotal moments. They said they didn't know what they would do without it, and how it was so important in facilitating them getting through their not only their birth, but engaging in parenting and mothering with their infants. So the bonding piece of it. So we had to sort of scramble to be like, okay, we got to do something really cool with this because we need to get it out there. And we felt sort of morally obliged to have our partners and the folks that we had partnered with in the community to sort of understand and see the potential in it. So Sheila O'Keefe McCarthy was the co-author, who is also part of the study, who did a secondary analysis with us to take a re-look at the data to see if we could transform it into something that was powerful, engaging, with an explicit intent to reach a broader audience, social change, social justice minded. And this was the paper that had come out of that. So there was some poetry written that reflected the themes that we found in the data. And then we had those transformed into works of art. Now, what's really interesting is at the time we had, volunteer artists who were going to create these works. So they read the poems, and whichever were the most resonant for them, they created their work. And then we, sort of went on a bit of a roadshow with the art to show it. And this was just basically to raise awareness and of how powerful this potential intervention could be, and just to show that these women are out there and that these are their experiences, and this is what's happening for them and why we need to care. What's really cool about this paper, though, is it's had huge uptake in the media. We've had an interview on CBC Radio, which is our public broadcasting corporation in Canada, several million listeners. So we were able to speak on that, and it's been in the news and so forth. So there's a lot of power in arts-based and arts-informed research, which is really why I love this journal, Creative Nursing, because we're finding different ways to communicate our findings and the important work that we're doing, which I think is really needed in the space of intimate partner violence and other forms of violence, right? So it's kind of like we're not just sort of beating the same drum. We're saying, hey, there's different ways to look at this, and isn't this cool? But more so than the most important thing, I think, with this is it's a different way to have our participants to have a voice, right? So now the fast forward to today, we're doing a few other arts-informed research projects, one of which is a Canadian-wide SSHRC-funded project where participants are actually creating their own works of art. So these are women that have been pregnant and then postpartum while experiencing intimate partner violence, and having them create the works of art to tell their story. So it's sort of a mechanism to enable storytelling, empowerment, and again, just sort of amplifying these voices. So as Marty had said, we were delighted to have some of these works of art from the previous project in this paper. So I would really love for you to go to the paper and have a look, because I think, you know, a picture is worth 1,000 words, right? And so you see these works of art and it just really tells the story. And what was most profound, I think, about this was that through all the, you know, the data and everything, what came through most clearly was that the women that were in this program had originally felt broken, and these are their words, but they had, through this, had become stronger and more resilient. And one of the most interesting portrayals was a painting of a woman who is carrying a pottery vase that was broken. I think it's kitsumi, where the Japanese repair pottery with gold and it becomes stronger and more beautiful. And that was just like the perfect portrayal of the stories that we were hearing, is that, you know, I may have felt broken, but I am now repaired and stronger for it. And not that they, you know, we want anybody to go through that, to feel that way. And that was the one, the image you just showed there. But it really just does, you know, sort of beautifully portray the experiences for these women. So again, just delighted to share this project and these works. We're so delighted with the work, this mosaic painting here, unbelievable, you know, mother breastfeeding her baby. And you can see all the little fragmented pieces on the floor and the mosaic pieces being put together, but the sunbeams coming in. It's a beautiful photo, and it just shows of that sort of light and hope and resilience and strength. So I welcome, I'm not sure how much time I have left, but I know I've probably been blathering for about 5 or 6 minutes, but I invite your questions and look forward to perhaps collaborating with some of you folks in the future. And again, thank you for this wonderful opportunity.
And this is like the opposite of blathering. I encourage you to go to the article, not only for the pictures, but the poetry is actually the narrative data in poetry form. It's so amazing. One other thing I just have to put in here. If as someone who's an editor of a journal called Creative Nursing, if somebody is in the middle of a study and lose their funding, and then they've got this stuff, it goes way back to my own postgraduate stuff, where a wise person said to me about the data I had, okay, what questions do these data answer? That can be the start of a paper. If, you know, I'm just putting it out there that if you have to take a turn in your study, there are lots of ways you can do it for a journal called Creative Nursing. So thank you, Kim. I would next like to introduce Jennifer Lane, who is someone who's been a colleague and supporter of our journal for many years now, as an author and a peer reviewer and a cheerleader. Jennifer is an assistant professor in the School of Nursing at Dalhousie University in Halifax, Nova Scotia. And her co-author, Neda Alzada, is here as well, and they'll tell you about their other co-authors. So Jennifer, hi.
Oh, hi there. It's lovely to be here today. I think this is such a great idea. So I know we're short on time, so I'll just get right into it. Okay. All right. Well, when this work was done, I was still a student. Actually, I was a PhD candidate, technically. And I'm always very forward with my identity. So I'm a mentally ill lesbian. And at Dalhousie University, there's all these equity initiatives, and there's kind of 4 priority groups, and so I kind of represent 2, with the sexual minority and disability. And so the School of Nursing is kind of at the forefront of a lot of these EDI initiatives. We had a EDI committee that I sat on for a couple of years. We undertook a curriculum review and developed an EDI rubric that we kind of appraised all the syllabi across all of the programs, and then met with course professors and told them how they could do a better job. We developed an admissions policy where seats were going to be saved for Black and Indigenous students to try to increase that representation. And there was some work around faculty recruitment and retention as well. The thing that I noticed, though, is these priority groups, while they're incredibly important, and representing two of them myself, it's not that I totally support it. However, you can't be inclusive of everybody if you're focusing on certain groups. And I noticed that approach actually doesn't really do much to address the underlying power relations that have been prioritizing certain groups historically. So, you see these new social hierarchies forming, and of course, this opens the door for structural violence, just to tie into the theme here with the journal. So, I was very kind of outspoken and organizing like lesbians do. And I was actually approached by a couple of undergraduate students. They wanted to explore research, specifically EDI research. I wanted to explore operationalizing intersectionality theory in quantitative research. I am trained as a constructivist grounded theorist, so definitely not a quantitative researcher, but I developed this sampling method when I was doing my PhD, and I wanted to explore if there was a quantitative application. So I supervised them during a self-directed study. We developed a survey, we distributed it, and we got a little data set that we could work with. So I started fiddling around with it. And I actually reached out to my supervisor. When I was working on the manuscript, I had already successfully defended. So I reached out to one of my former supervisors, and asked for some advice, because I was coming up against this block with the intersectionality piece and how to operationalize it. I was concerned with protecting the anonymity of the responses because the sample size was so small. These are students, and we were looking at sense of belonging. One of the questions was, has your sense of belonging been impacted since starting at the School of Nursing or being at the School of Nursing? And the other one was, are diverse groups included and represented in the curriculum? So it was kind of a critique of these initiatives ongoing. And, we discovered that unfortunately, there's not really much evaluation going on around these initiatives beyond head counting. And so that's kind of where that critique came from. So Ingrid Waldron suggested that I look at Patricia Hill Collins' concept of strategic essentialism. And then the ball just started rolling. So it not only protected anonymity, but it resulted, we were able to kind of recategorize the groups, and it actually allowed us to overrepresent historically underrepresented groups and currently underrepresented groups. And so just a quick note on language. The representation, we were actually defining it in relation to the broader social context of the study. So using census data. So it's not a comment on the populations themselves. It's literally just about representation in, where the study was being conducted. So once we got all that, the operationalizing intersectionality theory sorted, I was well aware of my limited quantitative skills. So that's when I reached out to my colleague, Netta, and her patience and brilliance in trying to bridge the gap between my lack of skills and not having a grasp of the language that I should be using. So lots of conversation. So I'm going to hand it over to Netta so she can talk about that part of it and how she came on to this, because she wasn't part of the original study, but oh goodness, did I ever need her to put together this manuscript.
And can I just say, if we can do 2 minutes more
Sure, it
before we
won't
go,
be,
yeah.
it won't be more than that.
Is that
So
okay, Netta? Thank you for being here. We're glad to have you.
yeah, thank you for inviting us. So yeah, I just a bit of myself. So I came from Iran and as an immigrant to Canada, and my background is in occupational therapy, not nursing. But you know, we've always been trained to reflecting on who we are, who are around, who are people around us, like to understand and to be able to deal with our biases. So that's why I was always interested in EDI, and then I know Jennifer for maybe 4 years now, 3 years now. So I knew how genuinely she's actually working in this field. So that was a honor to be working with her on this project. And yes, what we did, I mean, we all know that there are some limitations, and we've talked through a lot about how we can actually make it quantitative, especially because you know, when you want to go with the groups, so we have like one main group as overrepresented people, and then we had one group as underrepresented, but then we had subcategories in each of those groups as well. So we were going back and forth a lot to understand how we can actually start looking at comparing these two groups in their sense of belonging and inclusion in the curricula. But because that was a pilot study, and like we understand the limitations of pilot studies, so we decided to go with the two broad categories for now. Because of the low sample size, we weren't able to look at each subcategories there, which is part of the intersectionality theory and analysis. But yeah, just to make it quick, for now we just wanted to know what is the perspective of those that actually are in the program currently and how they feel it. And it's interesting that even with the low sample size, we found significant differences between the two groups for both outcomes that we had. But again, we understand our limitations, we understand the uneven sample that we had between the two groups and the low sample size, the low power of the study. But I think as a pilot study, this is a great start. So we can start looking at the larger sample size, more even sample size. And I know Jennifer is working on that, like really in multiple projects. She's doing like a lot of work in the sampling methods that she can make that happen in larger studies. But yeah, and the other important part of this study that I really like to focus is that many institutions are trying to take the initiatives of EDI, but rarely they measure it, rarely they evaluate it from different aspects. They, as Jennifer explained, so they just look at the numbers. Okay, we included these numbers, but are you actually including them? How do they feel about this inclusion? So yeah, that's why I really enjoyed and wanted to be part of this study. Thanks to Jennifer, I had this chance. And yeah, I hope I wasn't over 2 minutes.
Well, thank you both of you for this great presentation. And for me, you know, as the editor, I'm looking at the fact that if you say to an underrepresented minority group or person in that group, you say, okay, how do you really feel? What is it you want? That in itself can be a very aggressive, alienating thing. And so gathering statistics is great, but also guarding against doing that, because that's how alienating it can be. All right, well, thank you very much. I'd like to move then to our next speaker, who's Catherine Grano, an interim director of the School Nursing Program and clinical instructor in the College of Nursing at Rutgers, the State University of New Jersey. Catherine?
Hi, everyone. Again, my name is Kathy Grano. I am really grateful to be here with you guys today. You have some very creative, wonderful projects that you've undertaken and carried through, and I find it very inspiring to listen to all of you. So I did make a little PowerPoint to help me stay on task with you all. So let me just pull that up and get the slideshow started. I am from New Jersey in the United States. So this is where I did my research study. So the title of it was A Qualitative Study of School Nurses' Experience of Secondary Trauma. So we all know in this group that trauma is not only widespread, but it's costly. It's a public health issue that crosses all of our socio-demographic levels. Each year in the US, more than 10 million US children experience trauma, and a quarter of them experience a highly traumatic event by about age 16. So as you heard, I am the interim director of the school nursing program at Rutgers, and I have my backgrounds in maternal child as well as school nursing. So that was kind of my wheelhouse when I was going through my PhD program. Did I want to focus on maternity or did I want to focus on school nursing? But there's a lot of gaps in data regarding the school nurse and what they do. So the school nurse is our primary medical healthcare expert in school. They're accessible to students, right? Without needing transportation or money or, their parent to be there with them, which helps to eliminate some of those barriers. We know that school nurses before COVID, a third of their work hours were related to the mental and behavioral health care of students. So that's a lot between balancing their normal work duties, also dealing with the mental and behavior issues that our children are having. We know that an awareness of others' trauma can cause a variety of responses, from absolutely no effect to, mental issues to secondary trauma. So what inspired this study? I myself have stories of trauma in my students and my coworkers and their families. We went through Superstorm Sandy together in my area, and the recovery for that is, believe it or not, is still going. I think it's about 12 years later. So hearing their stories of loss on top of all their it was a lower socioeconomic area, so they were already struggling. So knowing that I had that experience, then I would go to national, state conferences, talk to school nurse colleagues, other colleagues in the school system, and I was hearing that they were also receiving stories of trauma from their students and from the families. So I did a literature search, right? I said, what is out there? And really what I found was that there really is nothing out there regarding the experience of the school nurse, if they're receiving trauma, and if so, how does it affect them? How do they respond and how does it affect them? So it was a qualitative study because I wanted to have the experience directly from the mouths of the school nurses. It was purposeful, right? A choice in my sample because I wanted to make sure that they had a couple of years of school nurse experience, that they had heard reports of trauma, and that they could use technology. This was done during COVID, so everything had to be online at that time, which limited my ability to do any kind of face-to-face with the participants. And then I did a qualitative content analysis. So what did I find? So the study did find that school nurses received reports of trauma to varying degrees. All of the people that I spoke to received it to some degree. Those in urban settings, which, one of the criteria there was all of the students, they were in an urban setting, plus the students, all of the students in the district were receiving free and reduced lunch, which is based on the demographics, right? But the nurses in the urban setting received more frequent reports, right? So they had more stories to tell me more frequently and a little bit more diversity in their stories than the nurses that I spoke to in the suburban setting. And these were numerous and layered traumas. It wasn't just a trauma here or there for the student, but it could also be built upon, throughout their life and their challenges. And all of these nurses were in grade 8. They worked in a grade 8 or lower. So we're talking about, age pre-K up to grade 8, which for us is age 3 to 4 up to about 11 or 12. So even though they had different amounts of exposure, there were certain patterns that I found. And through an analysis, these were the categories that I came up with. Health office as safe haven, challenges working within the school model, things that we hear, reports of trauma, and then the ripple effect of trauma, how it impacts others. So the nurses did say that they felt that the office was a safe haven for students, where students could come to them, they're welcome, they're accepted in a non-judgmental manner, and they could share their concerns with them. So that was seen through all of the participants. One of the participants said, it was a lot of trust building that needs to happen. They need to see that I wasn't judging them. You have to kind of come from them in a place that you can understand, so they don't think that you're looking down on them or anything like that. So they had that insight. The children had that insight. So the school nurses reported challenges working within the school model, obstacles such as school policy, things like if this report happens, who do they go to next? If a teacher is made aware of a report, who do they go to? The psychologist, the school nurse. So there was some challenges also in the lack of school-based collaboration, where a student is coming to the health office a number of times for stomach ache. And lo and behold, a week or two later, the nurse finds out, well, this child witnessed domestic violence at home. So having that collaboration with the other players in the school setting, such as the psychologist, is important so that we're able to address the needs of those students. Then the other thing they had to balance was the health office demands. So that's their workload, the amount of patients that they see throughout the day, the acuity of the care they're receiving, and what kind of resources that they had available. So things that we hear, reports of trauma. So this looked at the reports in the urban setting separately from what we were seeing in the suburban setting. So students shared stories of violence, including gun violence, incarceration or death of a loved one or someone that they were even just knew could be traumatic for them, neglect, as you guys were talking about, domestic violence within the household. The nurses in the urban setting shared similar stories, but they also shared more stories of poverty-related adversity. So these students were already, maybe they already lived in crowded housing conditions with multiple homes in a small apartment, or they had limited access to basic needs such as food, income to meet their needs, or medical care. So it was a little bit more voluminous in stories than it was when it came to the suburban. What we also found out is many of the referrals came from the teacher. So the teacher was the one coming to the nurse saying, hey, little Joey seems off today, can you take a look at him? With one of them, they had a family worker that worked within their school district, and that's someone who's enmeshed in the community and already has a relationship with the family. So one school, the family worker was their most common reporter. So the ripple effect of trauma, right? Hearing about stories of trauma can ripple into those hearing them. So the school nurses shared with me how they received and processed these reports. And I kind of categorized them under subcategories under the ripple effect of trauma. So in the eye of the storm, while they're receiving reports from the students, they're focusing on their immediate needs, right? How can they help? What can they do to support this student? Who do they need to refer them to next? Implementing strategies. So this is a quote from one of the school nurses. I'm pretty good at compartmentalizing myself. When I receive these reports, it's afterwards I have trouble sleeping, or I worry about it all night, or I think of something I forgot to do that weighs heavily on me. I don't think there's a greater responsibility than caring for other people's children, right? So that hits home. In the eye of the storm, so, weathering the storm, when they're kind of going through that process, they're still trying to help relieve suffering, hopefully reduce potential harm to the child. And sometimes their attempts to help were not successful. Sometimes they came up to, upon barriers, whether it was from the school system or from the family themselves. But during this time, they did share stories of concern, frustration, worrying about the student's future, and things that would basically stick with them is what they said. So one participant, if they chose to accept help, great. If they chose not to, well, I can't make them. So that was a participant who was trying to help a family who refused assistance. I can remember it like day. Those sat with me big time. So that was an experience that the nurse kept replaying in her head years later. Then we have mitigating the aftermath. Marty, you'll let me know if I'm almost out of
I
time.
was just I did in the chat. So if you can wrap up in the next few seconds.
You got it. Okay. So mitigating the aftermath was, what do they do to cope themselves, to reduce the risk of their own personal harm? And what we found was many of them were resilient because they had like 20 5 to 25 years in school nursing and 25 to 40 in nursing itself. So they had time to kind of build up their skills of resilience and coping, and did things that worked for them, whether it's walking, taking a nap, so forth and so on. So let me stop sharing, and I'm happy to answer any questions that you may have in the Q&A section.
Well, and
Thank
Kathy,
you.
in working with you on this article, when we got to the part about ripple effects of trauma, what I thought is this could be a whole article just in itself. The ripple effects of trauma. What a title. Well, thank you, Kathy. And I'm
Thank
hoping,
you.
we're getting further on. So I'm not sure how much time we're actually going to have for Q&A at the end, because we're going to give the full amount of time to the 2 remaining articles. But please, I just posted the corresponding authors' emails in the chat. Please reach out to them. Our next presenter then is Hans-Peter de Ruyter, another longtime supporter and fan of our journal. Hans-Peter is professor and director of the Glenn Taylor Institute for Societal and Family Nursing at Minnesota State University, Mankato. And he'll tell you about his co-author. So Hans?
Helps to get off mute. Thank you so much, Marty, and very nice to be here. Yes, I co-published this with Melanie, and she's a nurse in Austria, and this study really is historically based in Austria and in Germany. And I promised to do this in 5 minutes. I have my clock up here, so I'll go till 10:44. Just a little bit of a background. So I grew up in mainland, or with parents from mainland Europe. So I had the Second World War was always at the dinner table, and it's a fascinating time in history. There were so many programs in the National Socialist Germany that, we know about the Holocaust, but that is just one of many, many programs that were there. And one of the programs I want to talk about that really fascinated me for multiple reasons is the T4 program, which was the euthanasia program, where they don't know exactly, so the numbers kind of vary, but maybe about 700,000 people, mainly children, but also adults with disabilities, were murdered, or as they called, euthanized at that time. And why was that of interest for us? Is first of all, it was very strongly nursing run, and it ran to the medical, but it also was the foundation for the Holocaust. So this program really was the template. So it wasn't what we like to believe, all these evildoers that did it. No, it was nurses and physicians who basically were the foundation of the Holocaust and a lot of the things that we did. So when we were working on this article, and some of this actually evolved during the writing, I think the thing that we struggled with was, what is really the storyline in this? What was really the message we want to give? Because there's so many messages, there's so many conclusions, things. And it really ended up looking at how these things happen within an ideology or in systems where the ideology is predominant. And then we look around in the world right now, what is happening? And we're seeing all these ideologies, and some of them very scary ones, dominating. And we can look at Hungary, we can look at the Netherlands now, we can look at Germany, the most recent elections, we can look at this country and everything. And so how, as nurses, can we protect ourselves against slipping into what ideologies can be asking us to do? The chance that we're going to see something like the Holocaust or what happened in Nazi Germany is see a repeat of that is very small. So the way it represents itself in a changed world in different countries is going to look differently. So really the underlining kind of the idea is, how can we as nurses step back and look at what it really is our responsibility, which is often rooted within codes of ethics. So what we did is the study has been going on for a long time. Not that we've been constantly working on it, but we started about 10 years ago. Started at a euthanasia center in Austria. It's a historic site right now. And got an overview of what happened, and that led to going into the archives in trying to figure out all these. If you look at 700,000, or sometimes at one site 47,000 people were murdered. How do we reconstruct that to those being individuals again? Because often we just look at these numbers and it really doesn't tell us much. So through the archives of Linz in Austria, where a lot of the kind of faux medical records were, the study continued on in Berlin in the National Archives, where they have 48,000 records, and going through those records and recreating the stories of individuals. So there's 3 individuals. Very unfortunately, couldn't put the pictures of the individuals in there, but Marty got to see them briefly, because I think that was really powerful, that these were real. How did this play out? How does a system go? And how easy it is for nurses to slip into that. And there were also some people who didn't do that. And that as maybe a template of reflecting, if we end up in ideologies where it maybe means eliminating immigrants or treating people who aren't documented differently, or whatever the new ideologies are, what tools and what way as nurses can we speak up or look at that? And it isn't a clear answer. This is how we do it, but it is a discussion point in a world that is changing, and where some of those ideologies might be in contrast with what we believe as nurses. And I'll keep it with that. So for details, read the articles.
You mute, Marty.
Sorry, thanks. Yes, thank you, Hans. And I'm going to use like 1 or 2 of your remaining 2 minutes to highlight something that I, as the editor working with Hans on this article, this is a quote: "Nurses manage the process, ensuring that patients remained calm during transportation and during the final medical examinations before being escorted to the gas chambers. They, however, were not required to turn on the gas, as this was considered a medical intervention." This article, the category of this article, we have an ongoing feature called Reflecting on Our History. And most of the time, these articles are about neat, exciting, creative things that nurses have done over time. This is the opposite. And I want to say, I was telling a friend about this article who's not a nurse at all. He's a musician. But the part about what happened to these nurses after the war, there were trials for some of them. Most of them faded back into the background and were never heard from again, the ones who participated. But the ones who were at the time of their trials, a distinction was made between the ones who had to do this in order to keep their jobs. Maybe some of them had to do it in order to keep from being killed, but for many of them, it was they had to do it in order to keep their jobs. And my friend, who's a musician, went right to the fact that there were many musicians during the Holocaust. There are stories about them. There were the ones who collaborated. Did they do that? Why did they do that? And there were the ones who didn't, and what happened to them. So this article, I encourage you all to read it, although it is very sobering. So thanks, Hans, and thanks for all your work on this. We have one final article where the author was not able to be here, and I am going to present the article, and I'm going to try to summarize it as quickly as I can, because I do want to try to leave time for some questions, but also we are going to end at 11. That's when we said we were going to end, and so we will. So this article is from our Voices of Patients and Families feature, and the title is "The Experience of Family Members of Relatives with Substance Use Disorders, an Integrative Literature Review." The authors are Esther Minari. She's at Memorial University of Newfoundland in St. John's. Richard Booth and Cheryl Forchuk, and they're at Arthur Labatt Family School of Nursing at Western University. And then Rick Ciernik of King's University. Those are all in London, Ontario. So this article gives a definition of substance use disorders, which I think I won't do. I think we all pretty much know what that is. And if you don't, you can look it up. And so as family members continue to support their relatives who have these disorders, they have significant impacts, including stress, difficulty coping, and concerns, difficulty coping with the behaviors of these relatives that are addicted, and concerns for family safety and loss of family relationships. They also experience personal stigma. Some people might say, what's wrong with you? That you have this relative who has all these problems. And also it can be very, very socially isolating. I want to take a minute to talk about the methodology that these authors chose. They chose integrative review. Of all the different kinds of reviews there are, there's rapid reviews, narrative reviews, scoping, systematic. Integrative reviews, they chose it because they wanted to know about the experiences of family members. That was their calling with this article. What do these family members go through and what can we do to help them? Integrative reviews are a kind where you can put together all kinds of disparate methodologies and topics. So instead of contrasting or critiquing other approaches, integrative reviews put things together and they synthesize the knowledge. And this distinction starts with how you word the research question. So instead of saying, what are the characteristics of such and such? What they said is, what are the experiences of these people? What are their actual experiences? So they worked with a health sciences librarian, which is always a smart thing to do. And they chose the search terms: family members, relatives, individuals, substance use disorders, addictions, and experiences. Those are keywords that don't always show up in these searches, but those are the ones they choose. Then in another example of widening the discussion, they also included Google Scholar. In addition to CINAHL and PubMed and all those, they included Google Scholars and gray literature. If you're not familiar with this term, gray literature is evidence or documents that are not published by commercial publishers like Sage, Springer, and Elsevier. And they include academic papers, theses and dissertations, government reports, and conference papers. So from an initial cache of over 6,000 articles, they analyzed 26. And they identified 5 themes. I won't even tell you the names of the 5 themes because to me, it's the names of the sub-themes within these 5 themes that really show the richness of these papers. These are examples of some of the sub-themes: impact on caregivers of children with SUDs, impact of SUDs on children, spouses, and other family caregivers, violence, aggression, and related behaviors, conflicting decisions in supporting relatives, the dilemma of dual roles. What if you're both a husband of an addicted person and a caregiver of that person and having to make decisions about that? Factors contributing to SUDs, that makes sense. That would probably show up in any review, integrative or not. Barriers and challenges to coping and supportive resources and strategies. These findings underscore the importance of family members being able to recognize these disorders, because sometimes delay in recognizing it, whether it's denial or just lack of information, that can really delay treatment and have huge impacts. Children's experiences of parents' SUDs can result in adverse emotional outcomes that last a whole lifetime, including feelings of neglect and shame. There are cultural influences on that. And the barriers that were highlighted, they underscore the need for, these authors are saying, we need structured support. We can't just rely on the random kindness of strangers. There have to be structural supports. So that is this article. I encourage you to read it. It's a wonderful addition to this issue. So it's now 10:52. We have 8 minutes. And usually, since I'm the moderator, I get to ask a question to get things started. And I have a question prepared, but let's see if anybody, and go ahead and unmute yourselves at this point. We don't need to do the raise a hand thing. just go ahead and speak up. If you have a question, I'll wait about 15 or 20 seconds, and if no questions are forthcoming, then I'll ask mine.
Marty, I have a question, if that's okay, for Catherine.
Sure. Yeah.
Yeah, so Catherine, thank you for sharing your findings in your paper. It was really interesting. Our team does a lot of work with rural, how rurality and geography plays a role with intimate partner violence. And I'm just wondering, I know this wasn't, you sort of divided your data into urban and suburban, but I'm wondering if what you may have found, or if anything, or if you considered the sort of rural context and how that might sort of be different from what you found.
Yeah, so I pulled those categories from my participant interviews as to where they worked. So none of the participants worked in a rural setting. So I wasn't able to pull any data from school nurses from the rural setting. So the study needs to be repeated, right? I need to have a larger sample and more diversity. That is a goal in the future, to repeat it, to get more data.
Yeah, it might be
Thank
really
you for that
interesting.
question.
Yeah, my kids went to rural high schools, and I know that their experiences were vastly different from urban children's experiences. So I just thought, oh, that would be really cool to sort of see what you might find there. Anyway, thank you.
Mhm.
Thank you.
That was one of
I
my
had a question
editorials
for,
Oh, go ahead. Go for it.
I'm sorry, I was going to say I have a question for Kimberly, but go ahead, Marty.
No. Go for it.
Okay, so Kimberly, I was just, I wanted to know, for the artist for the initial poems, who, you said like later you had the women experiencing IPV do the pictures, but who did the initial artistry?
Thank you. Yeah, so we had reached out to our collaborations, so academic and also our community partners, to tell them about what we were going to do, and if anybody was interested in having a look at the findings, the poetry, and recreating works of art on the basis of those those pieces. And so the artists were volunteer, but none of them were professional. They were all amateur artists. And they were, anywhere from, we had a, doctoral student, we had a retired faculty, we had people from the public who were just heard about it and were interested. We had somebody who was working at a women's shelter. And we had just a person that I had known, just personally, who heard about it and was really interested in it. So these were all just volunteer amateur artists with this paper.
I know they do a lot of art therapy, right, for IPV and domestic violence. At least in my area, they do. So I would think that'd be a very interesting area to explore as they recover.
It's been a fascinating journey, and it's continuing. So stay tuned.
I don't have a comment, but I have a question, but I have a comment for Kimberly. When I read your article, it reminded me so much of my birthing class with my first child. I had to go to my bookshelf and find it, but the book is called Birthing from Within, and it has people's discussions of trauma and how they used artwork within their childbirth classes to heal from childbirth. And I really love that. And I've also seen similar papers where children that have been affected by violence also explore it through art. So very powerful. Thank you.
Thank you for sharing that. I love that.
I have something too that's not a question, it's a comment, and I haven't even prepared it beforehand, but I want to make a point about the role of peer review. We are a scholarly peer reviewed journal, and all of these articles have been peer reviewed by a content expert. And we are so blessed to have these people who are willing to spend their time and energy to do this. And all of you are on the list now. If you weren't before, you are now. So you're going to be getting invitations. And if you get an invitation from us to review and you can't do it right now, please do take the next step of letting us know of colleagues' names, because we may not know those people. And we are finding in this review process, all journals are having a lot of difficulty finding peer reviewers who will actually do the work, because after all, it's unpaid work. We're doing it for the love of our profession. But please let us know about additional colleagues' names. The content expert who reviewed Jane Sparks' article about gun violence is a physician in the state of Minnesota who has been very, very involved in this whole issue and is very intentional and has lots of good points. For instance, just as one example, he says, don't use the word gun control or don't use the term gun control. First of all, it's not that useful. What the heck does it actually mean? Second of all, it can be very alienating. The term gun safety, that may seem like a weasel word, but it's not. It's actually what we're talking about. Because if everyone in the world had a gun and none of them used it for anything except hunting animals, I know even vegetarians don't want you to do this, but no, hunting animals is fine. Target practice is fine. And defending your inside your home is fine. If everyone in the world had a gun and that's the only times they used it, we wouldn't even be having this conversation, really. So that's the level of expertise that our peer reviewers bring to this, and it's just very valuable. Any final comments or questions in the last 2 minutes?
Marty, I just wanted to say thank you for this and that the peer review process was delightful. The feedback I received was so helpful. It's not always that way. So I just wanted to say that you've done a great job with your choosing your reviewers. It was just a really, really enriching experience.
Mm-hmm. Yeah, we just are really blessed. Well, Parveen, do you have any parting words as our hostess with the mostest?
Well, it's been incredible listening to all the information about all the articles, and I feel like kind of, I'll spend time reading through in detail all of them. And it's sometimes you read through things, but it's a different experience when you listen about, how it has come to being and how people have written it, the stories behind it. So that's been a really useful sort of experience. So thank you, everybody, for sharing your knowledge, your wisdom, your work, and how you have done all of that work. And it's good to see you and good to know you, all of you. And I'll be very happy to be in contact for anything that I can help and support with or anything that I can contribute to. So, and I would hope that all of us would have that sort of sentiments for each other. So yeah, it's been really good. And thank you, Marty, for bringing all of us together. It wouldn't have been possible without you.
You're very welcome, and I love you all. Thanks for coming, and stay safe and well.
Thank you, everybody.
Thank you.
Goodbye.
Thank you.